our agenda rolling, and I'm going to do that by inviting two of Oregon's leading healthcare lawmakers to the stage. Senator Cedric Hayden serves as the Vice Chair of the Senate Interim Committee on Healthcare, and Representative Rob Nosse is Chair of the Interim Committee on Behavioral Health and Healthcare. Would you both please join me on the stage? All right. So the state healthcare agenda, of course, is always active and dynamic. In any legislative session, it's a critical issue. And as legislators, you're deeply involved in healthcare issues, kind of whether you want to be or not. But both of you have taken leadership roles in this environment. So as I mentioned earlier, your job is even more dynamic in this current environment, potentially, mostly because of, as I said, the pace of change. So let's start by exploring what you see on the horizon for the Oregon Legislature going into this next session. And so I've asked both of you to sort of think about what you see as the top 2 to 3 issues for the Oregon healthcare agenda from your perspective. They can be legislative, they can be factors that are going to affect you in the legislature. So I'm going to start with you, Senator, on this topic.
Well, thank you. And thank you for the opportunity to be here and speak about healthcare. It's something that's been integral in my life from the time I was born, growing up in a family of public health providers. My mother was a nurse and my father was a public health dentist. And so it's been something that's ingrained, and I've really been appreciative of the opportunity to come to the legislature and serve for the last decade in the capacity of a vice chair of a healthcare committee. So I've really appreciated that. And we see changes out there, and some of the things that I've not only observed over the decade that I've been in the opportunity to create legislative policy, but for the 25 years, 30 years prior to that, practicing dentistry in Lane County. And in healthcare, we take an oath there. It's called primum non nocere. And what that means when we take that oath is we want to do no harm, or we want to do no injustice to our patients. When you start in the legislature, you take an oath also, and that oath is an oath to the U.S. Constitution, an oath to the Oregon's Constitution. And I want to have you think about that for a little bit. How do you get from standing up for your Constitution, for your state, and for your nation, but entwine the do no harm for our patients? And so I think that's one of the top issues that we really need to take a look at in our healthcare delivery system, and I am really concerned that some of the things that we do in policy is actually putting a burden on our healthcare system that is stressing it to the point that it could break. And some of those things that we're looking at, we have, Rob and I, and those that we serve with, will have the opportunity to address. So some of you know that I spent many of my years at high altitude climbing when I was younger and more in shape. And we have a saying in high altitude climbing that disasters don't come all at once. They come as the lemons add up. And what that means is small things take place that if we're not paying attention to, you can have a disastrous outcome. One of those lemons that I think is in our healthcare system, and I've talked about this for a decade publicly since I've been on vice chair, is our open card system. We have about 10% of our population that has a phantom network, meaning we don't have the providers, and that is a policy decision not to mandate providers in our healthcare network, and that's about 10% of our Medicaid population. It fluctuates, but it's about 10%. So that's one thing that I hope in my last time here that I'll be able to address the open card system. Another one that's come up recently is the Medicare Advantage program is leaving our rural counties. Curry, Harney, Lake, Umatilla, and Union counties are not going to have a Medicare Advantage. In 2015, had the pleasure of working with Alan Bates and others, Lynn Saxon, to get dual eligibility in our Medicare system so that those that have Medicare that qualified for Medicaid could take the advantage of the Medicaid, but I don't think that our policy has addressed that very well. And we haven't identified those patients, and we haven't reached out to them, and I think we could do a better job with that. Other issues are pipeline or workforce issues that are coming up, that we need to address scope of practice and make sure that all our practitioners in Oregon are practicing to the top of their level. Some credentialing reciprocity issues we will be tackling this cycle, and I think we need to take a serious look at that. Just a few other additional issues.
Is he going to get all the time?
No, he's getting.
Okay. All right. Okay.
Just
He's
a
got it,
couple
don't you?
of, issues. I'm trying to compete with you here, Rob.
I'm going to be much more succinct.
Very quickly, redeterminations are coming up. We have audits with the state of Oregon that pointed out that $455 million in the last 3 years have paid for patients that have had services in other states. 29 million of that was with the state of Washington. And to wrap up, we have an issue with legacy health here in the metropolitan area. What are we going to do with that? Are we going to bail out legacy health through Oregon Health Science University, basically state funded? And if we do, has anybody addressed the PERS? Have we solved the PERS problem? Would the 14,000 people that come from legacy health onto a potential PERS retirement program affect that? So that's something that we need to be aware of. And I'm just concerned that that could turn into a family care 2.0. And I think it would be the wrong decision for us to take legacy health over from state funded. And I think we should let open markets work.
Senator, thank you so much for setting us up. Appreciate it. That was a great list.
All right.
Representative, what you got to offer?
I'm tempted to comment on the whole OHSU legacy thing, but I'm going to dodge. So for me, the committee that I chair, the policy area, it's fundamentally about what gets covered and what do we pay for, and then what provider is allowed to do what procedure or offer which treatment. That's the fundamental things that the Behavioral Health and Healthcare Committee discerns. That said, most of the things that I'm worried about are all about helping people get paid. So first and foremost, for me, going into the 2025 session is we have 1.4 million people in our state who are in the Medicaid program. That's a third of our state's population getting their health insurance through the Medicaid system. Half the children in our state are on Medicaid. So we need to compensate providers and hospitals for the care that they provide from the Medicaid program adequately. Next up for me is helping pharmacists and their businesses, whether it's a small independent pharmacy in a suburb or in rural Oregon, or whether it's the Safeway, manage to be financially viable when dealing with PBMs and their business practices. I don't believe that PBMs are going away. They serve a role, but pharmacies and pharmacists and their business model need to be better compensated and frankly treated better by pharmacy benefit managers. I've been not for forever, since 2021, trying to get the behavioral health care system to do a better job and compensate those better who do the care in that space. There will be bills about that. And I think a lot of you know I ran 3 6-hour meetings this summer to talk about the coordinated care model. I called them CCO salons. And I think we'll have bills that check in on the Medicaid model that we have, which is the coordinated care organizations, and how they're doing and what we can do to help them do a better job of delivering the Medicaid program here in our state.
That was very succinct, somewhat surprisingly
I prepared. I got notes here.
Terrific. I'm going to ask you actually to dive a little deeper on some of those initiatives. So maybe going with the CCO salons or something along those lines, what are you thinking are some of those solutions that might be coming forward, or what vision do you want to put to some of those ideas you mentioned in terms of if you want to move the needle in CCOs, if you want to move the needle in pharmacy, what are some of the ideas that you're thinking of putting forward in that space?
Most of the bills that are contemplated are ultimately about operations and about how those entities can have more money so that they can compensate providers better, or they can change the way their rates are evaluated, or we can do different things with the way rates are developed so that they have, frankly, a better ability to compensate the folks that are on their panels and are doing the provision of care. I don't know that I've got a whole lot more that's innovative in that space other than that, to be totally honest with you. As I often say, kind of flippantly, but it's true, everybody wants to be paid.
Both of you sort of referenced, you specifically, Senator, scope of practice. And I do think that those issues of who delivers the care, do we have enough of them, where are our access issues? Obviously, you're mentioning payment. What are some of the other things in the scope arena or other places where we can really work on the access to care issues?
So I think we have the opportunity, and I think we have in Oregon been innovative in healthcare. You know, we have gone from a lot of different acronyms and names, but, you know, we had welfare, and then we had DMAP, and
Senator,
then we had
can you pick
OMAP.
up your mic? Sorry.
And I have a microphone. So we've gone through a lot of different phases in healthcare, and I think we need to continue that innovation. As you know, you might have noticed that we had a recent election, and this election has changed the administration, but a lot of people in that administration aren't going to be your hardliners. And one of those people that we anticipate, yes, and one of those people that we anticipate is Robert Kennedy Jr., or RFK. My office has actually reached out to him, his office, and we are already in communications with them. And we want to talk with them and showcase what Oregon has done, and we think we might have the opportunity to do that. Some examples of that are Oregon is first in the nation to bring oral health care to veterans through our Oregon Dental Veterans Program. That a lot of people worked on, but it was one of the innovations. I think we're the only state that has that now, and we would like that to go, expand nationally. We were a leader in getting the COFA population covered. And so those are some of the examples that we have. You know, the federal government under the prior Trump administration did come in and cover that COFA population, but those are some of the examples of innovations that we have done. Some of the examples of innovations that we want to do in the future are a few things that we've done before, I've tried before through our office, and that's looking at making the food in the SNAP program healthier, giving credit for child care and earned income tax credits back to people monthly rather than annually on their tax returns, so that they have those funds at the time that they need the child care. And so I promised I'd be shorter on the rest of the questions here. So those are some of the innovations, and we've got a few personal bills that we'll be working on also.
All right, I have to ask, did you actually talk to Robert Kennedy Jr.?
I have not. My staff talked with their staff, and I hope that leads to that conversation, and I thought I was clear on that.
If you get to talk to him, make sure you tell him you're a dentist.
Okay.
Because he's a big fan of fluoride.
Yeah,
big
I
fan.
hear that.
Okay, he's a really big fan.
And
that's all he knows about Oregon.
And probably the Oregon dentist being approved to do vaccines in our office.
So, I think I've talked every time I've had a chance to talk, I keep talking about money. So, how do we have enough money to do things like getting more providers, getting them educated and trained, getting them paid, getting them located where we need them? How can we incentivize people to practice in more rural areas? How can we keep pharmacies open and compensated better in light of the way PBMs and insurance plans compensate them? Those are the things that I think about. Like we got a good revenue forecast yesterday. We're changing the way we project how we are going to evaluate what kind of tax income is coming in that we'll have available to spend. And maybe if we do a better job of that and it's more accurate and reflects what we actually take in, we'll have more resources this time for this session to spend on things like loan forgiveness or tuition or education reimbursement, something that since the pandemic we haven't been as generous with.
So I want to go back to something you said, Senator, about talking about the positives. And we had a small gathering last night, and one of the things that we talked about was sort of the reputation of Oregon and the reputation of certain programs and states in the federal perspective of the incoming administration. And to some extent,
I'm sorry I missed that, didn't I?
a lot of, well, there you go. A lot of what you all are doing may reflect well the priorities and may not, right? And so I'm just sort of wondering about how you think about going one level deeper, maybe in Medicaid, maybe in other programs, to what you are achieving and trying to achieve and who it affects. Is that something you're thinking about? I thought your point about dental and for services for veterans is really interesting because it resonates with a certain perspective that might be coming in. Any other programs or efforts that you'd want federal agencies to know about in your current environment?
Yeah, I think that we can and be able to share with our federal agencies. Like I said, our office is reaching out. We'll see what traction. We reached out to Mark Cuban a cycle or so ago. Never got any response back, but I was really interested in what he was doing with generic pharmaceutical manufacturing, right? And I thought that was something that Oregon could have tackled, and we've talked about it in our healthcare. I still think it's an opportunity there for us, but couldn't get any traction with his office. So I'm hoping that on the federal level we get some traction with them and that we can talk about our CCOs. You know, I think Oregon either has to say, hey, this is the greatest thing, or make some transformations, but some of those innovations still are yet to come, in my opinion. If we really want to truly transform healthcare in Oregon, we have a party that is in charge that has the ability to do it and has talked about single payer for a lot of years going forward. And I'm not a single payer advocate, but why haven't you done more? That's my question to my colleague. Why haven't you done more? And
It's really hard.
Yeah, it's complicated,
It's
right?
complicated.
So-
We have 5 systems for the healthcare
All right,
delivery
my
system in
turn
America.
still. So here, just really quickly, an example of that, for my bucket list, for my political career, I would love to see us take all of the health care that is funded by taxpayer dollars. Now, what I mean by that is, you know, we got the federal Medicare, but we got dual eligibility. Then we got Medicaid, and then we got OEB, and then we got PEB, right? These are the big buckets. And Kitzhopper, you know, I'll call it the Kitzhopper plan, or we could say the Save Healthcare, Destroy Your Political Career plan. But we could take all of that and put it into one bucket and say, we are paying for this health care and still have our commercial insurance out there. So I think that I would challenge my colleagues on the other side of the aisle, if you really want to look at transformation, look at putting health care that is paid by some sort of tax funding into a single bucket. And if CCOs are the answer, you know, put it in the CCOs.
All right, you know what? I don't hate that idea at all. Okay?
Consensus.
But I don't hate that idea at all. The thing is that the reason why there's resistance is because you get paid 5 different ways in the current American healthcare system, depending on who the payer is, whether it's Medicaid, whether it's Medicare, whether it's PEB or OEB, or the various ERISA plans or the various DCBS plans. And so we've been reluctant to sort of take all of the healthcare that's provided by the government sector, very broadly defined, and have it delivered under one system because we can't figure out how to make sure it balances out so that providers have enough compensation coming in when Medicaid doesn't compensate properly, when Medicare barely compensates, and when we make commercial insurance have to sort of overpay to compensate for the... So if you'll help me set a standard price like they do in Maryland for an emergency appendectomy at a hospital, whether it's Medicare, Medicaid, or commercial insurance, we can go there.
Okay.
So this
We
is
can work
fascinating.
on it.
So let me...
Maybe a Republican can get a waiver from the Trump administration to let us regulate hospital pricing the way they do in the state of Maryland.
So that's a great segue, because here's where we are, right? We have, let's talk a little bit about Medicaid state federal policy. Clearly there's been a lot of churn in the last couple of days. In fact, I think this morning or yesterday morning in the New York Times, that there's going to be changes. And there are 2 kinds of changes that can happen in Medicaid. There are Some things that the federal government can do, I'll call it unilaterally, but essentially trimming, changing some of the rules, et cetera. But a lot of the times, it's really offering more options to states for doing things differently. And sometimes that is more of a, there's fewer mandates in Medicaid than there probably is in any other program because it is a state, federal negotiated environment, right? It is almost a contract. So the last Trump administration sought to do things like block grants and work requirements. But to some extent, they sought to do those as state options. States could request to do those things, which is a very different environment than a mandate. Both are possibilities in this environment, as well as other funding cuts. But what you all are talking about is a state option, a state-designed intervention. Is that something that you think, I mean, it definitely has more appeal in a Republican administration at the federal level.
Okay, I'm going to go first this time. So, President-elect Donald Trump didn't really campaign on health care this time. It was a tier B political priority. He didn't talk about the ACA very much. I don't really think he talked about Medicaid at all, to be honest with you. And so, as someone who is very anxious about his presidency and what the Republican Congress might do, my inclination is to say we've got a good thing going here. Don't go knocking, and just say, put our heads down, nothing to see here, pay no attention to this part of the Northwest. He doesn't even like Portland.
Shocker.
And then just, we'll see what, and just sort of just kind of do our thing and just sort of say, ignore us, okay? So I've set you up. Now you can tell me, here's what we should do instead.
So it's not Vegas. Like they say, what happens in Vegas stays in Vegas. What happens in D.C. does not stay in D.C. And so putting our head in the sand or having an attorney general that says we're gearing up to sue the federal government for
Only if they do dumb things.
Z.
Only if they do
Right?
dumb things. We don't need to go to court unless they do dumb things.
Okay, I think it's the wrong approach. I think, sending the message that some are sending now that we are going to be the the new blue wall out on the left coast, right? We're going to be the resistance. I think this is the wrong message. And I think that, Rob, you picked up on something pretty prominent.
Right, we're going to put our heads down here. Let Gavin Newsom take all the hits.
Okay. That they didn't campaign. The campaigns really weren't on Medicaid or even Medicare. There was some talk about Medicare and covering, in-home services for family caregivers, and that's actually something that I support for parent caregivers, and one of the bills that I didn't cover in the first because I was taking too long, but hopefully, we're able to move the dial on that. But I think that the debate on having some sort of Medicaid program in the states is ingrained, right? It's not going to go away. There's not going to be a big vote to take it away. But what we do with those waivers can be effective.
Well, we're in the middle of our waiver.
Well, then we're going to have to do another one.
I know. He in his last year of this term, our waiver comes up again.
Which brings in basically the hospital tax or the provider tax, the hospital assessment, however you want to say that. That is a conversation that is coming forward and something that we're going to have to tackle. So the funding, we can't just keep writing the checks and be able to fund the rest of the things that we want to do in Oregon with the escalation of healthcare costs. So there's got to be some innovation coming forward.
What do you want to stop doing?
Well, I want to put it in one bucket.
But then that means you're going to lower what providers get paid because you're driving it toward how Medicaid compensates as opposed to how ERISA plans or DCBS regulated plans pay.
No, I think if we work with our federal partners and we say, hey, listen, over the last 3 years, our audit said that we spent $445 million duplicative on health care, and we get our federal partners to say, we're going to do real-time redetermination, and we're going to say billions and billions, and we're going to put half of that back into block grants or something for community health benefit for the savings. So that's how you work with the federal administration to say, hey, here's a problem. You're spending all this extra money that we're taking, but that money could benefit the patients better.
I would certainly propose that money is more likely, in my opinion, to drive the decisions about what happens with Medicaid at the federal level than sort of principles. The idea last time around with President Trump's first term was repeal and replace. It was all about taking something down. The only conversations we've heard, not in the campaign, but are about money. And so I do think that positioning around what you can do to control costs and other interventions could resonate with this administration coming.
So let me just finish this with my part with saying, you know, you really don't want to bite the hand that fixes your tooth. Put it in a dental term, right? Why? Because that's the hand that's holding the needle, okay? So we really don't want, I don't think we want to put Oregon in this position right out of the gate that we're resisting the federal administration because they have the purse strings.
You need to go on the Oregon Public Broadcasting website and read the article where the reporter talks to people who complain that Governor Kotek and Oregon Democrats in leadership are too subdued. We're not charging the ramparts here in this state just yet. We're putting our head down, nothing to see here. Look at California, pay attention to them, don't look at us.
Well, I certainly think they will
We'll
be looking
see.
at California. We'll see. And that is the point. We're having this meeting several months before we know much of anything. So really appreciate the willingness to sort of postulate in this environment. So let me see if there's anything maybe more local, turning a little bit more local. There were some things that were raised in your opening list, Senator, as well as yours, Representative. So are there things more that you feel are directly in your line of sight? Less federal interaction. Sure. Let's talk a little bit more about the agenda, Oregon Senate agenda, for just a few minutes, and then we can see if...
So for sure, PBMs, I think, are something that we can deal with. The Senator brought up interstate compacts. I know one of my colleagues in the House is very fixated on whether or not that approach will get more providers to work in our state. So I would say stay tuned about that. There was one other, slipped my mind. You answer, and then I'll come back to it. I'll think of it.
So if we're talking about some of the bills that are going to be coming out of my office, it's not a whole lot. My friend and colleague here told me when we were prepping for this last week, I got 40 bills coming. I said, great, Rob, I'll see 2 or 3
Well,
of
now
those.
some of them don't make so much sense.
I'll see 2 or 3 of those on the Senate side.
I told you that before the election.
So, you know, I've got 3 prominent bills. I've got more than that, but I've got 3 prominent bills. We talked about them a little bit, but preventative. I really think that we could focus on preventative. One example of that is the cardiac calcium screening that we can actually detect if somebody's going to have a cardiac arrest earlier, and I don't think we spend enough money, particularly in that area. It's very expensive, cardiac care. So I think we could do screening. That's a bill I'm actually going to bringing back. I mentioned parent caregivers. There is nobody, and I say this as a parent of a disabled child, and after doing 30 years of servicing disabled people in a hospital setting for oral health care or dentistry in a hospital-based setting, there is nobody better to take care of those kids than their parents, right? Yeah. And so let's find a way, just like we need to find a way to keep seniors in their homes. It's less expensive than to have them go to a care facility as long as they can. Let's find a way to fund those parents to take care of their own kids because they're really the best suited for it, and it's not taking jobs away from anybody else because those caregivers are not there, but the parents are standing by to do it. And then a new bill that I'm looking at also extends on that concept. Now, when these children with rare diseases and disabilities that, you know, are lifetime and they turn 26, if they're not eligible for Medicaid, you know, they might get some sort of Social Security benefit, but they drop off, right? Why do we push them off their parents' insurance at 26 just because they turned 26? So a bill that'll probably be controversial even with my side of the aisle, I would like to see in those cases where we have diagnoses for these children to remain on their parents' insurance as long as their parents are alive. Why do we separate them? And I say that from the aspect of dealing with this population for a lot of times, even when they would move across a county line, those kids would get ripped away from their providers. And my office would spend months tracking them down and working with the CCOs, and we'd have this geographical barrier. We've really come a long ways on that from DCOs solving that geographical barrier, but we have this age barrier with disability. So that's one of the things I hope to accomplish this time around.
Wonderful. Thank you, Senator.
I like all those ideas. I'm sure we'll have bills about scope of practice and who gets to do what, and I'm sure there'll be bills about mandating that insurance cover certain things, certain procedures, so that'll come up as well. And then ultimately there'll be bills about compensation and how people get paid, and should a naturopath be paid as much as a physician when they're doing the same thing in primary care? Should a mental health counselor or a psychologist who's working in a pediatric clinic be compensated for the same way as a pediatric physician is when they're doing the same thing, but insurance compensates the physician one way and compensates the mental health therapist another?
Wonderful. When we were getting ready for this session, you both talked a little bit about outside factors that might slow the health agenda. We've talked a little bit about the federal aspects that might slow the health agenda here. Are there any other components of the wider legislative world or other issues that might impact or slow our ability to take some of the actions you've just described and apparently agreed upon?
So I think Governor Kotek is laser focused on housing because it's expensive to live here. Rent and mortgages are too high, and we don't have enough of it. And when we don't have enough housing and people are either rent burdened or worse, don't have a place to live, it makes it pretty hard to be adherent to whatever your treatment regime is, and to be adherent to whatever your provider is asking you to do to maintain your health. And then she's also very laser focused on trying to just make our behavioral health system more robust. I have other colleagues that are a little more obsessed than I am about trying to make it more organized and more efficient. But given that we have not enough providers, particularly in the adolescent space, I'm mostly more focused on how can we just have more of those folks. So those are two things. And then I suspect our session will still be dominated by schools and school funding, which is a little indirect in the healthcare space, but parents kind of suffered through the pandemic and schools kind of limped along, and now they're kind of coming really back and they're complaining about not having enough money, not having enough staff, and lingering pandemic effects. So I suspect that shows up, and then ODOT's out of money, and that may suck up a lot of oxygen as well in terms of our session, in terms of what we do about transportation.
Thank you. Anything else, Senator?
Well, I agree that there's going to be a lot of issues coming forward, and one of the points that I'm trying to make here today is that in our healthcare, we traditionally haven't put a cost of living increase on it. Current service level is the way that we refer to that in the legislature, and that's something that I've argued about. That we always seem to say, well, we've got to have the healthcare, so we're going to go out and create this additional tax, or all the kids won't have healthcare. Right? So I think that we need to transform our thinking on that, and we need transportation, we need good education, we need libraries, we need these things that the government, the state government really should be providing, but we need to treat healthcare equally with those things and have a current service level increase on that rather than always going back to the taxpayers and say, well, you got to have more, we just had the budget come out, looking at another kicker. We have had kicker after kicker after kicker. So there's lots of money there, but we're not balancing it right. So
are you saying you'll take a vote to keep the kicker?
No, I'm not saying that. I'll take a vote. The kicker needs to go back to Oregonians. I'm saying we need to be more efficient with that. Just a couple examples of that we do. You can't constantly ask the provider to take a smaller check, right? That's not working anymore. You can't say, hey, you got to do these duplicative audits. And by the way, if you mess up one thing, OHA is going to go back and claw back all your premiums, because if you messed up this one chart, they make this assumption that you messed up all these other charts. So we're going to take back $200,000 out of your small business. We can't keep doing that, right? If the service was provided, we can't keep putting it on there, making more requirements for them, making them, when I was providing healthcare in multiple hospitals, I would have to do credentialing for every entity that I dealt with.
You want to take on credentialing?
And it's all the same
That's awesome.
thing, right? And I think we should have a one-stop type credentialing.
I agree. If you're
and-
licensed, why do you have to be credentialed?
Well, I agree.
Okay, good.
It was Patrick Allen that killed that, right?
Well, it's because our computer systems couldn't figure out how to do
We
it.
got better computers now. We
Maybe.
just don't know how to use them. And then the last point I want to make on that is our rate setting. I think we really need to look at our rate setting, not just in oral health, but in physical health, and particularly mental and behavioral health. We kind of have a rate setting system that's blue sky. It's like, hey, 3.4%, that sounds good. Yeah, well, let's ingrain that forever, right? Maybe that doesn't make sense, and we need to challenge some of that thinking, and I think we need to put a current service level on our healthcare funding.
So the two of you have been wonderfully transparent and a great dialogue. I want to cast the net out there beyond the floodlights and sort of ask you both, from the people in this room, from provider groups, from hospital systems, from the CCOs, from patient groups, et cetera, what do you need from them to accomplish some of the things that you've been talking about? What kinds of input would be helpful? What kinds of information? Anything that you would ask them to be thinking about going into the session?
Well, to the extent that you have an idea that isn't very expensive or doesn't cost money, that we could change a statute or an administrative rule that's getting in your way, you should bring those ideas forward. We hear a lot about administrative burden. My colleague talked a little bit about it in terms of things like credentialing is a good example. If there is a process that we make you engage in that you don't think is adding very much value, you should try to get us to get rid of that. Now, everybody's program that's worthless, there's somebody else that thinks that's a really important thing to be doing, but we should try to figure that out and have, and tackle some of the things that, are taking the joy out of providing care, because it's really just tracking everything as opposed to actually helping somebody.
So mine is really simple. If you want to help me continue to work with my colleagues and others to help this healthcare policy, it's real easy. Repeal 113.
Oh, wow. Are you going to not walk off the job all the time then?
Okay, so that's the ballot measure that basically put term limits on me. Okay, that joke didn't go over, but
I thought it was really fun.
But seriously, there is an aspect that providers do in their offices all the time, whether it's mental health providers, dental providers, physicians, the whole scope of it. They provide a tremendous amount of non-reported care for Oregonians. Sure. Millions and hundreds of millions of dollars probably every year. And the reason is the burden to be paid 50 cents for something that cost you $1 is too much for them to have their time and their staff spent on that. And we really need to address that. We have, 12% or so of panel networks of actual providers involved. And I'm saying if you strip away the phantom networks out there, the networks that our CCOs put together, our commercial health networks put together that say, hey, we've got this big panel, but then the patient takes that little piece of paper and it's like, well, that person only accepts me if my family member goes there, right? Well, that person only takes me on Tuesdays from 9 to 10 p.m. And you really start to look at what those panels are out there. They're phantom panels. And we need to address that through our policy, that we can get a higher level of practitioners participating in the system, and we do that by paying them appropriately.
I think that's especially true in behavioral health. I know a lot of therapists and counselors that don't take insurance. They make their patients pay out of pocket because they're not reimbursed enough, but also because they don't want the hassle.
Yeah.
Well, this has been a wonderful conversation. I want to thank you both. It has been. It has been for me. I've enjoyed it. I hope all of you have as well. And a great start to our day. Thank you both.